All right, let's dive into a problem that, well, it haunts hospitals everywhere. The revolving door. If a patient leaves, they get home, and then far too often, they're right back. Emergency room, readmitted, sometimes just days or weeks later.
It's an incredibly tough cycle to break. Think about someone like Mrs. Jensen, the example we discussed.
Oh, wait.
She goes home after treatment for pneumonia. Maybe she's elderly, a bit weak, juggling, I don't know, a handful of new meds.
Yeah.
And critically, she lives alone. So a week later, her breathing gets worse, she's confused, probably scared, and bam, back in the same hospital bed.
And that really gets to the heart of it, doesn't it? The human cost. It's immense.
Absolutely.
For Mrs. Jensen, it's distressing. It's a major setback in her recovery. It might even lead to worse complications down the line. It's just grueling.
Yeah.
Emotionally, physically.
Totally grueling.
Yeah.
And then there's the financial side, which is equally staggering. I mean, the sources we looked at point to actually tens of billions of dollars every year in the U.S. alone, just tied up in readmissions that, might have been avoided. That's money, resources that could be used so much better elsewhere.
So the big question, the one we're tackling today, is can we get better at predicting this, anticipating it? What if we could actually see, before a patient even walks out that door, who's most vulnerable? Not just the really obvious cases, but the subtle ones too.
The ones that slip through the cracks.
Exactly.
Yeah.
Pinpoint those sort of hidden factors, putting them at high risk, and then actually do something about it. Tailor the support, specifically for them.
Well, traditionally, predicting that kind of risk has been incredibly challenging because, like Mrs. Jensen's story shows, it's rarely just one single thing. It's complex. And that complexity, that's where something really powerful is starting to enter the picture.
Artificial intelligence.
Right.
AI. As of, today, May 30th, 2025, we're seeing AI increasingly being brought in as a tool, a way to get ahead of this problem, to predict, to prevent, and hopefully to drastically cut down on these readmissions. So our mission in this deep dive is really to explore how AI is stepping up, how it's becoming this crucial ally in closing that frustrating revolving door, helping patients get home and actually stay home. And we're basing this all on the material you've shared with us.
And I think to really appreciate what AI brings to the table, we first have to get a handle on the sheer complexity of why patients come back.
Okay.
It's like this tangled knot, our sources highlight, it's not usually a single thread, but this really intricate weave of clinical factors, social factors, even systemic ones.
Okay, let's try and pull apart some of those threads then. Starting with the clinical stuff.
Sure.
Obviously, you've got ongoing medical issues from the first hospital stay. That makes sense.
Right. Unresolved problems.
Then there are complex other health problems, comorbidities, right? The sources mention things like heart failure, diabetes, kidney diseases, common culprits.
Yeah, very common.
And medication issues seem huge too. Maybe confusion about all the different pills.
Or bad side effects.
Right. Or sometimes just not being able to afford them. Or maybe not understanding why they even need to take them.
Exactly. And of course, new complications cropping up after discharge, like infections or wound problems.
Okay, so that's the clinical bucket. But then you add in the stuff that doesn't really show up on a standard medical test.
Yeah.
The social determinants of health. SDOH.
Ah, yes. This is where it gets really challenging for clinicians who are just looking at the chart,
I bet.
Lack of social support is massive, especially for frail patients or those with cognitive issues or, like Mrs. Jensen, people living alone.
Yeah.
Food insecurity, unstable housing. These aren't medical diagnoses, right? But they can completely derail someone's recovery.
Totally. Or transportation barriers. How do you get to your follow-up appointment? Or pick up your prescription if you can't get a ride.
Precisely. And health literacy is another big one. Just not fully understanding those complex discharge instructions or the medication schedule, when to call for help is a huge factor.
Those SDOH factors often feel kind of invisible when you're just focused on the vital signs and lab results.
They can be.
And then the system itself can sometimes contribute.
Definitely. Poor discharge planning is one. Inadequate patient education, maybe unclear instructions, not setting up home support properly.
Or lack of care coordination.
Yeah.
Like the hospital team doesn't communicate well with the patient's regular doctor.
Exactly that. Poor handoffs. Or just not having timely follow-up care actually scheduled before they leave. It all adds up.
Okay, wow. So when you look at that whole picture, the clinical complexity plus the social challenges plus the system gaps, it becomes pretty clear why it's so hard for clinicians, humans with limited time and often incomplete information about a patient's life outside the hospital. Why it's so hard for them to reliably predict risk for every single patient.
They're trying to connect hundreds of potential dots, often in real time, under pressure. It's a massive cognitive load.
Right, and that's precisely the challenge, the gap that AI is increasingly being built to help solve.
This is where AI really starts to shine. It, particularly machine learning or ML, is uniquely powerful at untangling that complex knot we talked about.
How so?
Well, it can look at vast amounts of data, much more than a human could process. And it finds patterns, connections, influences that are just incredibly difficult, maybe impossible for a human to spot consistently across every patient.
Okay, so what kind of data are we talking about?
What AI is brilliant at is data integration. Think about it. A clinician might see the current EHR, maybe some recent notes. AI can pull from, well, almost everywhere. Not just the electronic health record with the diagnoses, procedures, labs, vitals.
The usual stuff.
Right. But also claims data, which might give a much longer history of hospital use. Pharmacy records showing prescription refill patterns that can hint at adherence issues, right?
Oh, okay. Clever.
And crucially, that social determinants of health data you mentioned earlier.
So data collected through specific questionnaires, maybe, or linked to census data based on where the patient lives. Screening tools used in the hospital.
Exactly. Bringing all of that together, it paints a much, much richer picture than you'd get from just the typical medical chart.
It builds a much more nuanced profile of the individual.
Precisely. And then the machine learning algorithms get to work on pattern recognition. They learn from thousands, maybe millions, of historical cases where readmission did happen.
Okay.
And they figure out the complex recipe, the combination of factors that predicted it. It's not just looking at factor A or factor B in isolation.
It's looking at how A, B, C, and D interact.
Exactly. It's the interplay, like the example you sometimes see in the source material. AI might discover that the specific combination of, say, heart failure plus moderate kidney disease plus being discharged on a Friday.
Friday, really?
Yeah, sometimes that pops up maybe due to weekend support gaps, plus living alone, plus having a key medication change during the stay. That combination creates a disproportionately higher risk score.
Higher than just adding up the risks of each factor individually.
Much higher. AI can weigh hundreds, even thousands of these features simultaneously: length of stay, prior admissions, lab trends, vital signs, changes in function, social vulnerability scores, looking for those subtle fingerprints of risk that a busy human team might easily miss.
Okay, so it finds these complex patterns. What does it do with that information?
Well, output of this pattern recognition is typically a personalized probabilistic risk score.
Like a percentage chance.
Yeah, you might get a number like, this patient has a 73% predicted probability of being readmitted within 30 days. And this score isn't just an interesting prediction. It's an incredibly powerful tool for taking action.
Because that score lets the healthcare teams stratify patients, put them into different risk categories like low, moderate, high.
Exactly. Low, moderate, high, maybe very high risk. And that is absolutely critical for resource allocation.
Right, because you can't deploy an army of support staff, transitional care nurses, pharmacists for every single patient walking out the door. There just aren't enough resources.
Precisely. Risk stratification means you can focus those limited, valuable human resources on the patients who, statistically speaking, are most likely to need and actually benefit from that intensive support.
Makes sense.
The sources describe these scenarios where AI flags a patient who maybe clinically looks pretty stable on the surface, but the AI sees these hidden combined risk factors under the hood, maybe a history of medication non-adherence it picked up from pharmacy data.
Because the doctor might not know.
Right. Or maybe no caregiver support was identified during a social screening, and perhaps a subtle lab value trend over the last few days of the stay that on its own isn't alarming, but when combined with the other factors just edges them into a high-risk category.
Wow. Okay, so that's where the prediction moves from just being an interesting insight to becoming a truly actionable strategy.
Exactly, because knowing who is high risk is only valuable if it leads to tailored prevention efforts. AI empowers the teams to intervene proactively before there's a problem.
Okay, so how does that actually look in practice? What kind of interventions are we talking about?
Well, first, targeted discharge planning gets a real boost. High-risk patients, the ones flagged by the AI, they receive enhanced planning.
Meaning?
Meaning maybe spending more time on patient education, perhaps using techniques like teach-back to make really sure they understand, or having a clinical pharmacist do a much deeper dive into medication reconciliation, explaining everything clearly. Making early referrals for home health care or community nursing support.
Getting things set up before they leave.
Critically, yes. Ensuring follow-up appointments with their primary doctor or specialists are actually scheduled before the patient even leaves the hospital building. And sometimes the AI's output can even give hints about why the patient is high risk, which helps the team know what to focus on during that discharge teaching.
That's smart. And presumably the support doesn't just stop at the hospital door.
No, absolutely not. AI helps personalize the post-discharge support too. If the AI flags, say, complex medications or potential social isolation as key risk drivers,
Yeah.
then that patient might get proactive telemedicine check-ins, maybe within 24 to 48 hours of getting home, just a quick video call to see how things are going.
Okay.
Or they might be enrolled in a remote patient monitoring program, using wearable sensors, maybe smart scales or blood pressure cuffs at home, where AI algorithms can analyze that incoming data and flag worrying trends early.
Like weight gain in a heart failure patient.
Exactly. Or maybe a social worker is specifically assigned because the AI highlighted transportation barriers or food insecurity issues. They can then work on connecting the patient with community resources.
So the core idea, based on what we've read, is that the interventions become really tailored to the individual's specific predicted needs and risk factors, not just some generic one-size-fits-all approach.
That's the goal. Highly personalized support.
And this again ties back to using those resources effectively, right? With AI doing the risk stratification, those valuable high-touch resources, the care coordinators, the nurses, the social workers, can be directed precisely where they're statistically most likely to have the biggest impact.
Right. It's about moving away from purely subjective judgment or spreading resources too thinly across everyone and towards data-driven targeting.
Which should maximize the chances of a smooth transition home for those patients who really need the extra help.
And the good news is this isn't just theoretical anymore. It's not just research papers.
Okay.
We're seeing this shift happening in real-world hospital systems right now in 2025. The sources we looked at highlight some really encouraging results from places that have implemented these AI-powered models, importantly, coupled with those directed intervention strategies.
What kind of results do they see?
They're reporting significant, tangible reductions in 30-day readmission rates, especially for common conditions like heart failure, COPD, pneumonia.
Significant, like?
We're talking reductions cited in the range of 15% to 30% in some well-documented cases.
Wow, 15 to 30%. That's a huge step forward.
It really is. And the impact just ripples outwards from there. It's obviously better for the patients, preventing the trauma, the physical decline of going back into hospital, making them feel more supported during a vulnerable time.
Better patient satisfaction, I imagine.
Definitely. And it's better for the healthcare system overall, reducing those billions in costs we talked about, freeing up hospital beds and ER capacity, allowing savings to potentially be reinvested elsewhere.
So the potential is very real.
Very real. And the benefits are starting to be demonstrated, provided, and this is key, that the AI insights are smoothly integrated into the actual daily clinical workflow and paired with effective action.
Right. It's not magic. It's a tool that needs to be used well.
Exactly.
Of course, as powerful as this sounds, bringing AI into this sensitive space, it's not without its challenges, its practical hurdles. Our sources definitely touch on these as well.
Oh, for sure. A big one is simply data quality and interoperability.
Garbage in, garbage out.
Pretty much. AI models are only as good as the data they learn from. If the data in the electronic health records or other systems is incomplete, if it's inaccurate, if it's not standardized, well, the predictions won't be reliable. They could even be misleading.
And getting different hospital IT systems to actually talk to each other smoothly, that's still an ongoing struggle, isn't it?
It is. Interoperability is a persistent challenge across healthcare.
Okay, what else?
Algorithmic bias is a huge one. Really crucial ethical consideration.
How so?
Well, if the historical data used to train the AI reflects existing biases in healthcare delivery or outcomes for certain groups, maybe based on race, ethnicity, socioeconomic status, even just where someone lives.
Then the AI learns those biases.
Exactly. It can inadvertently perpetuate them. It might unfairly flag certain groups as inherently higher risk, or conversely underestimate the risk in other historically underserved groups. So there's a huge need for continuous auditing of these algorithms for fairness and equity.
That's critical. What about just the practical side of using it day to day?
Yeah, integration into the clinical workflow. That's a major practical hurdle. Getting the AI's predictions, the risk score to the right clinician, the nurse, the doctor, the care coordinator at the right time in their process.
Before discharge, presumably.
Right. And in a way that's easy to understand and actually act upon. You absolutely want to avoid just adding more noise, more administrative burden, or creating alert fatigue where people start ignoring the prompts.
Yeah, clinicians are already overloaded with alerts.
They are, and related to that is trust and acceptance. Clinicians need to trust the AI. They need to understand, at least conceptually, how it works, what its limitations are, and feel confident using its recommendations to guide their decisions, not replace them.
And patients, too.
Patients, too.
Yeah.
They need to understand, in simple terms, how this technology is being used as part of their care. Building that trust, both with clinicians and patients, takes time and really clear communication.
Okay. Anything else, Major?
One final point the sources raise is interesting: the why factor.
The why.
AI is often fantastic at predicting who is likely to be high risk. It gives you that score. But it might not always clearly explain why for that specific, unique individual in a way that feels completely intuitive or actionable to the clinician on the ground.
Ah, I see. The prediction is there, but the underlying reasons might be buried in the complex algorithm.
Sometimes, yes, and clinicians really need that why to tailor the interventions most effectively. What specific factors should they focus on for this patient? So it really highlights the need to combine AI's predictive power with good old-fashioned human clinical reasoning and empathetic patient interaction to figure out the best path forward.
It's a partnership, not a replacement.
Absolutely. So addressing all these challenges requires a multifaceted approach. Better data governance, developing AI tools with fairness baked in from the start, user-centered design for clinical tools, and lots of ongoing education and support for staff.
Okay, so wrapping this all up then. Hospital readmissions clearly are a really complex problem. They've got deep roots in clinical conditions, yes, but also in social circumstances and even systemic healthcare issues.
Definitely a tangled web.
But AI is emerging as this genuinely powerful new lens, a new set of tools to help us see that complexity more clearly and, crucially, address it proactively.
By being able to integrate these vast amounts of diverse data, spot subtle patterns that humans might miss, and then enable targeted, personalized interventions, AI is really empowering healthcare teams.
Yeah, it's not about replacing their judgment or that essential human connection and empathy.
Not at all.
It's about giving them smarter insights, better strategies to use during that absolutely critical time when a patient transitions from the structured environment of the hospital back to their home.
Helping bridge that gap.
The vision here seems clear. A future with healthier discharges, much smoother recoveries, and a significant reduction in the number of patients getting caught in that disheartening revolving door.
And AI is proving to be a key enabler for making that vision a reality, which ultimately means better outcomes for patients and a more efficient, more effective, maybe even more sustainable healthcare system for all of us.
A really promising application of the technology.
It is, and it makes you think, doesn't it? Given the incredible complexity of factors AI can now identify, many of which, as we said, might not be obvious on the surface, how might a deeper understanding of these individualized risk factors change the way you, or maybe someone you care about, might approach that transition home after a hospital stay in the future?